Well, here we go. We're going to talk, I mean, this was, a lot of this stuff in the first half was my grist for the several years I was in London Health Sciences. And then things broadened out when I was in Boston, and broadened out a lot when I came here. Partly because the interests diverged, meaning there was healthcare, medicine, but also I got into this whole area of biology and evolution and all that kind of stuff. It really was very extraordinary. And I'm still very interested because the stuff is moving along so quickly, and that's why I included some material, added it in today, because the stuff is like March of this year. And so let's move along, and I can never remember which. Well, I love this one. It's a slide. Here we are. How fast your brain ages is affected by 64 genes. Now, it sounds like a gimmick. It really isn't. The UK developed a brain bank. I think there are about 125,000 brains in it, meaning they had MRIs done. They were healthy at the time at various ages. So there was a bank that people could draw on. And then some years later, when the technology allowed, they did as many complete genomes of those people as possible. So they then combined the two, and then they looked for the so-called brain deficit, meaning they had a program, quite a sophisticated program, for reading the MRIs and identifying evidence in the MRIs that would indicate the biological age of the brain, if you follow what I said. Then they compared it with the chronological age of the brain to see whether certain people had deficits, so-called brain deficits. It's a horrible term, but you get the idea. Well then, okay, what's happening with those people? Did they have let's look at the genome. And were there reasons for that? And there were. And they managed to narrow it down. I was quite surprised that the number was that low. It's interesting, when I did the aging series, I used as the central text a work by a Nobel laureate in chemistry, really an extraordinary one, and it's a great book, a gem to read, but he got into this whole subject, and there were several of some pharmaceuticals that act on some of those genes actually exist now. And one of them that he was taking is this drug called, it's an immunosuppressant, ribomycin. And I gather not a few other scientists are taking this without admitting it, but on the hope that it actually works. Anyway, so I thought that was an interesting one to kind of get going. I'm not going to get into this. This was the first one. Remember, it was on signaling in the nervous system. I'll tell you, the reason why I got into this as the entry into the series was that, it's almost hopeless, it's almost impossible to analyze how the brain functions, signaling within the brain. First of all, it doesn't especially tolerate electrodes and probing around in there, but the signals are so complex that it's very difficult to analyze. But the peripheral nervous system is right there, it's a freebie. And the basic pathological and physiological processes are the same in the central and the peripheral nervous system. So you can take lessons, you can learn from things. And when you identify, for example, in the peripheral nervous system, that some of there are only certain things that happen to nerve cells. I'm not talking about biochemically, but from a functional point of view. And one of them is that when they're affected, often transmission in the nerve fiber, the axon is slowed. Sometimes it actually comes to an end, blocked. Sometimes those nerve fibers break down. And sometimes when nerve cells are lost in the peripheral nervous system and in the central nervous system, surviving brothers and sisters, neurons, pick up the slack and form new connections to the cells that have been deprived of the connections. But that only works for so long. But it's really effective. For example, you have to lose about 50 to 60% of the nerve cells in the substantia nigra in the upper brainstem in Parkinson's disease before you get any symptoms. In other words, by the time somebody has the earliest symptoms, they've lost about 50. Yes.
Can you see this on MRIs and other scans?
Well, you can't count it that way, but certainly in modeling, you can certainly do that with various species. There's experimental models. There's a lot of evidence to support that. Yeah, there's a lot of evidence to support that. And probably it's very similar, that number, in Alzheimer's disease and the other dementias as well. Meaning, and I'm going to deal with that a little bit later, you see. And so by the time symptoms develop, people have already lost a substantial number of cells, which has implications, doesn't it? If you're trying to teach it or treat it, how do you treat it if the cells are gone? There's no rebirthing of cells in the nervous system. So you're dealing with what's left and slowing or stopping whatever process is going on. But cells don't regenerate in the central nervous system. Maybe a few examples of that, but not much. So anyway, that was that first time. So to get into this prosaic stuff, the Medical Research Society in the UK in World War II developed an anatomical kind of book for the armed services. It's a classic, and I have a copy at home. Kind of gruesome too, because of these terrible injuries, shrapnel, bullet wounds, blast wounds, and all that kind of thing. But this whole issue was related to anatomy. So, and it's been it's a very accurate atlas, and the drawings were done very well at the time. And this is one that shows the median nerve, which I'm going to talk about right in here in the carpal tunnel. Why do I focus on that? It is the single most common peripheral nerve injury, probably the single most common neurologic lesion ever and in the world. It's extremely common. Most people, including me, sometimes wake up with a little tingling and a thumb, or maybe the adjacent finger or the thumb, and you kind of straighten the arm out or move it a little bit, it goes away. So that's really very common because it's caused by a nerve going through an increasingly anatomically narrow tunnel. And as we get older. And here's the underlying, or here's the anatomy of it. There's the hand, there's the transverse carpal ligament. If I had, well, the wrong thing, I can't get my head around like this. But anyway, there's the carpal tunnel. It's about 2 to 3 centimeters long. And it covers, I'll just walk around over here, but it covers, here's the whole, somebody's sliced off the hand here. This is the back of the wrist here. These are the muscles that extend the fingers and the thumb, that kind of thing. And if it's in front, they're flexing the fingers here. But here's this little nerve. It has this very tough retinaculum or fibrous roof here. There's no give in the bones behind. So if there's any swelling in these tendons here because of inflammatory disease or trauma or whatever it is, or cumulative trouble over the years, it cramps this space, and guess what begins to show symptoms? The median nerve. And it's no surprise that this really is the most common cause of symptoms. What's going to happen here? Let's see. Now, this is didn't want to do that. Gotta go back. I'm going to back. because this is the little surgical clip, which I thought I had in here, it's working. Interestingly, this came from the UK.
87 men and 192 women per 100,000
Can you hear that?
population worldwide.
Okay.
Common signs include paresthesia, pain, and weakness
I
in
mean, it's
the
kind of
median
dull
nerve
stench
extension of the
listening
hand.
to it. Except when it
Symptoms
comes
of
to the
carpal tunnel
operation.
syndrome develop owing to excess pressure on the median nerve as it passes through the carpal tunnel, which is a narrow enclosed space in the anterior portion of the wrist.
This is kind of professional standards.
The borders of the
kind of
carpal
thing
tunnel
too.
begin with the transverse carpal ligament, or flexor retinaculum, as the roof. The ulnar side is composed of the hook of hamate and pisiform bones. The radial side is made up of the scaphoid and trapezoid bones.
So we're just talking about the bones in the back
The
of the
floor of
wrist.
the tunnel relates to the first proximal row of carpal bones.
Yeah, he's-
In combination, the anatomy creates a natural groove known as the carpal arch. When covered with the flexor retinaculum, the carpal tunnel is
You can
apparent.
feel your own here.
The contents of the
Beyond
carpal
that
tunnel
little
consist
crease
of the
here,
median nerve
that's the
and
beginning
nine
of the carpal
tendons.
tunnel.
The
And if you
tendon of the
feel
flexor
here,
pulsus longus,
there's the length
the
of my
four
carpal
tendons
tunnel.
of the flexor
That's
digitorum
how long
profundus,
it is.
and the four tendons of the flexor digitorum superficialis. Compression of the median nerve as it passes under the flexor retinaculum leads to the symptoms of carpal tunnel syndrome that were described earlier. Note that the palmocutaneous branch of the median nerve branches off 5 centimeters proximal to the carpal tunnel, passing over the flexor retinaculum. This anatomy explains why sensory symptoms do not occur in the palmocutaneous distribution of the hand, but only in the digital nerve distribution supplied by the median nerve.
So it's really these three fingers and half of this one.
Most cases of carpal tunnel syndrome resolve with 6 weeks of conservative management. Mild to moderate cases may respond to a trial of splinting or glucocorticoid injection. Refractory or severe symptoms are likely
This
to
isn't
eventually
done
lead to surgical
much at
intervention.
all anymore. In fact, sometimes cause trouble.
Surgical release of the carpal
If you
tunnel
injected
by
the
means of
nerve
an
itself.
open method has been the main surgical treatment option for more than 100 years. However, in the present era, an increasing number of centers are adopting an endoscopic approach to carpal tunnel release. Both approaches result in similar long-term function and pain for the patient. Complication rates are also similar. However, an open release has the advantages of a shorter operative time, less required equipment, and therefore lower cost.
Yeah, really see it.
Endoscopic release allows for faster post-operative recovery and return to work, as well as a small incision and cosmetic scar. In this video, we present the salient steps to performing both open and endoscopic carpal tunnel release procedures.
Even to a list
Before
of
any surgical
the
procedure,
tools.
obtain valid written consent from the patient, highlighting the intended benefit of surgery and
Now,
any
only 20 or
complications that
30
may occur.
years ago, the physician would have a white coat
Before a
on,
carpal
a
tunnel release
tie,
is attempted,
and a
an
shirt.
understanding and competence in
And,
basic surgical skills is
Things
required.
have changed.
Gather the necessary equipment. You will need a scalpel with a number 15 blade,
Yeah.
2 pairs of surgical scissors, one for tissues and one for sutures, tooth forceps,
Don't go
box,
home and try this.
a needle driver, sutures, and an electrosurgical diathermy device. Some surgeons may also elect to use an inflatable tourniquet to reduce intraoperative bleeding.
Plastic surgeons.
To perform
Do
an
that all the
endoscopic
time.
release, you need the
They
same
don't like
basic
blood in the
equipment
operative
as an
field.
endoscopic camera stack, a camera guide with a blade, and synovial dilators. Both procedures are performed while the patient is under local anesthesia.
This
and
is
the anesthetic process is the same
done
for
under
both
vocal.
operations. For an adult patient, we generally use 11 milliliters of
By preference.
0.25% levobupivacaine
They
anesthetic.
don't particularly like watching this.
Up to 1 milligram dilution. Place the patient's arm in the outstretched position.
Yeah.
And then infiltrate the skin and subcutaneous tissues that overlie
But
the
it's
body.
interesting the way
Extend the
surgery is
infiltration
evolving
of
now.
distal
More and more
crease
work
to
is
the
done at
tan line.
outpatient and out of hospital. And so these are ways of doing that. So you don't have to, and people of our age don't tolerate general
Mark the
anesthetic
base of the
nearly
distal
as
skin
well,
crease
so it's a
in line
good
with the
thing.
middle of the fourth digit.
Um,
Draw a line from the ulnar border
I
of
love
the
this.
thumb
I've never seen a
across the
surgeon
visible
do
bone,
this.
which can often be felt as a P-shaped
Maybe they do.
prominence.
Now,
This is called Kaplan's line, and it forms the distal extent of the carpal tunnel. Now,
I think
extend
I
the
can
line
feel
from the
mine
base of
without
the fourth
drawing the
digit
line.
to the mark made on the distal skin crease of the wrist.
what they're trying to do is limit the length of the
Mark a
incision
small
here.
deviation towards the ulnar side of
And,
the wrist. This is called the ulnar chevron. To start an open release, make an incision from Kaplan's line to the distal border of the ulnar chevron. If the incision must be extended proximally, follow the lines of the chevron to prevent skin contractures from forming on the flexural surface of the wrist.
Yeah.
The chevron is deviated toward the ulnar border of the wrist to avoid damaging the palmocutaneous branch of the median nerve. Markings for an endoscopic release differ slightly. Mark a 12mm transverse line proximal to the wrist crease. Some surgeons may choose to make this mark more proximal for ease of
And
camera
this is
insertion.
as basic as
However,
surgery
you
gets.
must always ensure that the distance from the incision to Kaplan's line is within the reach of your endoscope.
You kind
Test
of
the
learn
patient's
this stuff in the
sensation
first few
proximal
months of
and
your
distal.
residency.
When a tourniquet is used to reduce
And,
bleeding, exsanguinate the limb and inflate the tourniquet.
It's getting rid of the blood.
To perform an open release, start by drawing the surface markings demonstrated earlier. Make an incision from Kaplan's line
So here
down
we
to
are.
the distal end of the ulnar chevron. Make sure that it is long enough to expose
Well,
the proximal
it's
and
actually
distal
very
fibers from the
clean. It's a
ligament.
bloodless field.
Next, dissect
Because-
the exposed and palm fascia.
You're not paying
Note
attention.
that in
Yeah,
some patients,
and
may come
volunteers will be asked for at the end of the
program
program here.
from the ulnar side.
So they're actually cutting through
You may simply pull the fibers out of the way if
the
you
ligament.
can. Once you see the transverse carpal ligament, continue by making an incision into the carpal tunnel centrally. Using Mayo scissors, blunt dissect into the carpal tunnel and raise the transverse carpal ligament distally. You can
This
also
whole
use a
procedure
cross
is
dissector,
about 10
mosquito
minutes.
gun, or elevator
Um,
for this part of the operation.
And talk about
Using a
cataract
scalpel,
surgery being
release the ligament
taking
distally
15,
under
20
direct
minutes.
pressure. You will
Well,
know
this
you
is
reach
a
the distal
competitor
border
for
once you
cataract
encounter a
surgery.
bulge of palmar fat
It,
coming from Kaplan's line.
it's a very simple
Reposition
procedure.
yourself to look up the arm from the tip of the hand. Now use the same approach to release the distal end of the antebrachial fascia in the forearm.
Yeah.
To do this,
I just
raise
want
the
you to see the
fascia and then release
endoscopic
it under direct
procedure,
pressure with scissors
because the
or
endoscope
inverted
is
scalpel.
taking over
Note
the
that
world,
some
isn't it? I
surgeons
mean, if you've got a
extend the
cardiovascular
incision past
problem,
the
if you've got
ulnar
an
chevron
arrhythmia
of the
or
procedure
some
to
problem with
facilitate
your heart
early
these
access to the
days,
antebrachial fascia.
guaranteed 90% of the
Although
time
the
it's going to be a
release of
catheter
the scar, it is
up
thought
your
to
radial
reduce
artery
risk
or
pain
the
in
ulnar
days
artery,
immediately after the procedure.
artery, and
The choice here
kind of-
depends on the surgeon.
kind of gently kind of push along right up into your heart and then visualized,
Next,
and then they
check
can
that you
kind of
completely
deal with the
expose
arrhythmias. But it's a
fascia.
very, very
Wash the
common
wound with saline.
procedure. It's
Close the
really
stitches
radically
with your
changed
choice. Here, we use a non-absorbent
cardiology.
fluoronylon.
In fact, it's kind of put cardiac surgeons almost out of business
Bandage.
because the medical side can do these endoscopic
Now we will
procedures.
show an endoscopic release.
And also,
Make sure the
neurologists do
lines
these
are
kinds of
shown
things
in
for a
place.
stroke. To
Make
get
a full
clots
thickness
out,
incision across the
using
mark
an
proximal
endoscope.
to the skin crease.
works beautifully,
Blood dissect down through the subcutaneous
and,
fat using
and it's very
bilateral
satisfying.
to achieve
And
the
it actually
distances.
doesn't take very long.
Continue down until you can identify
The main
parts
thing
of this
in the case of surgery
If
for
this
stroke,
tendon is
the
obscuring the
endoscopic
surgical
approach
movement,
is
reflect it radially out of the
how
way.
short is that period between the stroke and when
fascia.
they actually do the procedure.
Using forceps,
And
pinch,
best if it's 3 hours, 6 hours, you get away with.
using the dissecting
Much more
scissors.
than that,
Next,
and,
release the distal
there's a
antebrachial
major risk
fascia
of brain
proximally
injury.
up the arm.
meaning
Note
a
that
good
if
chunk
you're
of the
using
brain has been
tourniquets,
deprived for
release the
oxygen
distal
too
antebrachial
long
fascia should be performed at the
before
end
they
of the
get in
procedure
there and take the
in order
blood
to
out.
prevent bleeding from obscuring the endoscopic view.
Okay, so here's the endoscopic. So this is where the entrance is. This is proximal, so right in here.
Create a plane for your endoscope using synovial
Awfully
diameters that
healthy
sequentially
looking hand.
increase in size.
And
Use
young person
saline
in
for adequate lubrication.
probably in their 40s. So,
As you do this step, to avoid advancing into Guillaume's canal,
so we're really just
aim
making
for the
space
workspace
for the
between
endoscope
third
here.
and fourth metacarpals, feeling for the hook of hamate bone ulnarly. Use an elevator to clean the underside of the carpal ligament by removing the synovium. You should feel a washboard effect as you do this. If you have not used a tourniquet,
Almost done
you
this.
may omit this step to reduce bleeding and obscured vision. Be sure to attach the endoscope to its guide and check the blade before insertion.
Oh, there,
Be
that's
sure
the
that
view
the
for
camera
the
is right
endoscope.
balanced and that anti-fogging solution has been applied. Press
And
on
that's
the patient's
the,
hand distal to Kaplan's line
the ligament
to
he's gonna
identify
cut,
the distal
or
border
she
of
is
the
gonna
carpal
cut.
tunnel.
Here and the roof.
Cuts through the transverse carpal ligament with the blade trapped
And
in
that's
distal
what the
carpal.
surgeon's doing right now.
Check to
See
ensure
that
that the
the
full
thing is got
thickness of the
splitting bone,
transverse carpal
dividing
ligament is
over.
being released.
Here, Rita, why are you?
Continue your
You do it
down the entire length of the
to
carpal
chickens
tunnel.
and turkeys. Why are you worried about it here? And
When you reach the proximal end, readjust the skin hooks to protect the skin as you cut through the final fibers.
well, we don't have to keep going on this, and I'm going to move on. So here's one to be aware of. This is the second most common nerve thing, which I really hadn't dealt with in the first week. Guess when this happens? Driving cars, particularly truck drivers, because they're for many hours sitting in that lovely cab seat with their resting their arm on it, holding the steering wheel, so that tightens up the pressure on the ulnar nerves, and the elbow's resting on, and it's not resting on the elbow. It's not this, as my mother used to say, don't do that. It's this. Because the cubital tunnel is really in here. It's not right at, I'm actually resting my elbow here on bone. That's not what's causing this cubital tunnel ulnar nerve, it's this. So if you imagine yourself sitting in a nice sofa at home watching TV and both arms are up like this, resting on the side, no wonder you might get a little tingling in your baby finger and maybe pay it no account, particularly if it's in happy hour time. But it's the long drives too that really do this. And so there's the ulnar nerve here going behind the, you can feel it yourself, that bone on the inside, okay? So the nerve is actually going behind there. In fact, if you feel there, you can just rub that nerve just above that bone. Can you feel it? Yeah. And if you press hard enough, you get a little tingling. So if you push your finger down a little bit, maybe another centimeter or two, just feel that the nerve disappears. It disappears into a tunnel called the cubital tunnel, where most of the trouble takes place. Can you feel that? Yeah. So it's that cubital tunnel. Oh, that's uncomfortable. You got to press on the nerve in the cubital tunnel. That's the vulnerable site. And it's really important because the ulnar nerve supplies a lot of the small muscles of the hand, responsible for dexterous movement. If you were a pianist, you certainly wouldn't want your ulnar nerve injured. And this is, I put this up because Grant's Anatomy is a classic. I mean, Toronto for years and years was really well known as they had excellent teachers. And Grant was a professor and head of the Department of Anatomy. He did all these dissections himself. And for years and years and years, they were in a museum. You could go in and see all the actual limbs dissected out like this. And, but it has the virtue of a beautiful dissection that's accurate. And, but here's the ulnar nerve, which you just felt here. There's that medial, that inside bone here, right here, going behind it here and into this cubital tunnel. That's where most of the trouble, when it dips into that, it's like the elbow carpal tunnel. You understand?
Is
Yeah.
that your funny bone?
Yeah, funny bone. Yeah. So, and then it's been opened up a little bit more on this side, or over here on the right-hand side, so you can see some of the bread. Now, this is one thing that always used to bother me, particularly with orthopedic surgeons. I mean, they're good friends, but they're also impatient and rush, that kind of thing. And these nerves get their blood supply. Little branches coming in, tiny little ones. If you're not watching, it's very easy to just kind of nip them. And if you nip too many of them, you're actually cutting off the blood supply to the nerve. So you're actually creating more trouble than you're solving. And the plastic surgeons were in some ways not any better, because if you put a tourniquet around the arm, you don't see the blood vessels. There's no blood in them. So I was like the neurosurgeons. They were the best balance. They actually understood it was a nerve and it needed a blood supply, and they carefully identified blood supply and they preserved it. So, and that's over 3 institutions, those kind of biases. So I don't know if they're still true now, but they might be. Here's a kind of classic example. Just to put this in perspective, this is looking at the signal here recorded from these muscles here. And I can tell you that this is right across the cubital tunnel here. And not only does the response drop to less than 50%, meaning that transmission is blocked in 50% of the nerve fibers here, but the conduction velocity has gone from around 55 meters per second down to, in this case, believe it or not, about 3 to 4 meters per second. That's a huge drop in transmission speed. And when you get down that low, transmission block is very common, and that's exactly what this person had here. So this is the normal transmission time right down here, so you can see how extraordinarily slow transmission was across, in this case, the cubital tunnel. So that's getting back to that signaling talk that from the first session. And those, kind of the equivalent of those things happen in the central nervous system. And here's this will be one of the last of these kind of slides I'm going to show you, except that it shows how extraordinarily abnormal some of these common nerve injuries can be. And this is a person right over here, where the size of the response proximal to the cubital tunnel is down by about 80%. So 80% of the nerve fibers in this nerve aren't functioning. And furthermore, the transmission is so slow that in myelinated nerve fibers, I think I told you in the first day of this kind of thing, in the myelinated nerve fibers, the nerve impulse skips from node to node to node to node. It's very efficient. It's a very efficient way to get high speeds without increasing the diameter of the nerve fiber. But what happens, the cost of that is that if those internode segments have lost their insulating sheath, transmission really grinds to almost a halt, or sometimes just barely gets by. And that's exactly what's happening here, because the transmission speed here is down to, believe it, 1 meter a second. And it's 60 meters per second beyond that. The reason why the electrical signals are so large is that it's no longer skipping along like this. It's taking its time, it's very slowly moving along continuously along the whole fiber and creating large currents. And that's why the electrical signal is so large. So it's actually a classic example of a very severe nerve injury. And I remember this person who actually, believe it or not, recovered after this surgery and got a good functional recovery after about 1.5 years. This is an interesting story here. This is a fellow who was in his, I think, mid or late 20s, loved to play hockey. And he was checked, and he fell on his elbow and crushed the nerve, and the nerve was almost non-functional for almost a year to a year and a half. But it came back, more or less. Then he got into a tussle with his wife. And she said, and he agreed, that she swung her purse at him. And it happened to hit the same nerve. I saw that fellow 4 days after the purse hit. And there was a response. This transmission speed across this thing is less than 1 meter per second. And almost all the nerve fibers are blocked. And furthermore, the survivors, well, only about 10% of them survived. But, good to be in your 20s or 30s. Here we are 2/3 of a year later. Nerve fibers are very slow to regenerate, maybe 1 or 2 millimeters a day. But if they do, then you can get quite a good recovery. And that's him at 2/3 of a year later, 220 days, and he did quite well. I mean, both of them, it wasn't trying to be nasty to him, but anyway, whatever happened. And it was a good marriage, and they had, I think, 3 kids. But anyway, 2 hits, 2 major hits. One in hockey, and then a spousal one. Yeah. Here's one. I like the story of this. This is the radial nerve. By the way, you can feel the radial nerve here. If you feel go down about, divide your upper arm into thirds. So there's the first third, second third, and go down to the junction of the second third and the distal third, and you can feel your humerus. You feel the bone there. And if you just feel around there, I just caught my radial nerve. There, the radial nerve has come from behind here, wraps around the back of the bone and comes out the side. And so there it is. You can see it here coming down here. That's what I can feel approximately here. I can feel it a lot better here, where it comes out of cover here. And it supplies all the muscles that extend the thumb and the finger. So it's actually very important. Just try this. If you try to squeeze the hand, well, hold it up like this so the wrist is straight, and squeeze. Now, bend your wrist. It's very hard to sustain that power, right? You need the stabilizing effect of the extensor muscles. Do you follow what I'm saying? Okay. Maybe not? Okay, well, let's just try it. Squeeze my hand. Don't break it. All right, really hard. All right, oh, come on now. My grandmother's better than that. My grandmother's better than you. Now, turn the wrist like now, squeeze really hard. Yeah, there it is.
Wow, yes.
Perfect. So just try it on yourself. So you really do need the power of extension in the wrist. This fellow came from around Windsor. He was in his late 20s. He loved to party, drink, took drugs, had a great time for him. And I saw him the morning after. And he had been, I guess they're a great group of these kids and gals and having a wonderful time. And he was in the hot tub. And guess what he was doing? He had his arms over the side of the hot tub, right on top of the radial nerve. And of course, because he's loaded, he didn't notice anything. The first he noticed was trying to get dressed after this thing. And he had 2 floppy wrists like this. He couldn't extend the wrists or his fingers or his thumbs. And so he caught the radial nerve right here. And fortunately, this is the kind of thing that from Grant's anatomy, you can see it buried in the triceps muscle coming out on the side here. But these recover very nicely. Now here's, just to compare a normal and an abnormal side. So here's the normal side for this, and everything kind of looks normal. But over here, this is stimulating the nerve proximal to the spiral groove, and then stimulating it beyond the spiral groove. These should be the same. They're not. So the transmission's blocked here at about 80% of the nerve fibers. But these recover. So as long as he doesn't go back to the hot tub or make that a regular habit. He's an interesting character. I mean, I think I met many more interesting characters in London than I ever met in Boston. That's hopefully not me. So, but don't worry about it. Now, this Ross, okay. Is it not you? Okay. One of my colleagues in Boston was Alan Roper, and Alan's a great guy. He's now senior editor of the New England Journal of Medicine, a full prof at Harvard. And who is that? Oh, okay, all right, don't worry about it. And he had the authority to put his own title on this article, and he called it sciatica. And I got after him, I said, Alan, well, a little bit of history here. Up to maybe the mid-1930s, pain and weakness in the leg was often, the default label for it was sciatica. It was presumed to be the sciatic nerve. And, but it turns out, as you well know from the second talk and your own experience, that 95 or more % of those are related to the L5 root or the S1 root up in the back. That's where they come from. So I said, well, why are you calling this article sciatica when you're talking about a rare problem, which I actually hadn't seen until I was exercising over in the community center on the elliptical trainer. And I kind of sometimes push the limit, probably for my age. And boy, all of a sudden I felt this pain in my butt and in the back of the calf. And I'm trying to analyze this, but at the same time realize that I got to get off this damn thing. And of course I initially thought it was probably a root problem, but no, I was actually a genuine case of sciatic neuropathy. So I sent off a little note to Alan that yes, sciatica actually exists because I had it. And so I think he enjoyed the joke. But sometimes, I mean, I remember when I was a kid being very delirious. I had pneumonia. I think I was probably 7 or 8. And in those days, they gave you intramuscular penicillin every 6 hours. And the nurse would come in and roll over, expose your bum, and then this. In those days, no disposable needles. These were all reusable dull needles. And if you're not careful where you stick the thing, it could go right into the sciatic nerve here and produce a devastating injury. Well, fortunately, it didn't happen to me or most people, but anyway, so. And just the last of these, some people get this from crossing their legs, right? It might be a long play or whatever is going on, and they don't notice or they don't pay any attention to the fact that they're getting tingling in the top of the foot. And what it is, this, by the way, is the radial nerve of the leg. All 4 limbs are homologous. The upper and lower limbs are homologous, meaning they may look different somewhat, but the underlying anatomy is the same. So here's the radial nerve here, but the common peroneal nerve in the leg here, and it comes around that you can feel a little bony prothofibular head just above your knee. You feel that? Yeah, that fibular right above your knee. Where are we? Where are we? There we are. Yeah. Okay. Yeah, so it wraps around there. It's superficial, therefore more likely to be compressed. And it also, like the radial nerve, almost invariably recovers and does well. Some of these injuries these days, I suppose most commonly with motorcycle or bicycle injuries and people being knocked over and land on the fibular head. And I'm not going to go through this. Now, I want to change where we're going here because Huntington's disease as a cause of dementia is quite uncommon. It's a dominant gene, and clinically it presents often, the earliest symptoms are some version of psychosis or abnormal behavior. And then they develop kind of so-called choreiform movements, and then the dementia comes later. And there isn't any treatment for it, and it's relentlessly progressive to death. Now, what actually causes it? Well, it's actually a fascinating thing with lessons for Alzheimer's disease and the other neurodegenerative diseases. The abnormal gene here codes for 3 bases or nucleotides: cytosine, adenine, and guanine. So CAG, that shouldn't be Q, it should be G. CAG. And sometimes genes kind of make mistakes and they create doubles or triplets of 1 or 2 bases, or in this case 3, but the number's usually less than 10. And you remember from the 2 Nobel Prizes in the last 2 or 3 years, if you learned anything, you learned that that function follows form. So if the structure of a protein is abnormal, it affects the function of the protein. Okay, but here the number of repeats is begins. It's a heritable disease. Begins after fertilization, and if one of the couple happens to have it, that kid is going to have it for certain. It's like autosomal dominant Alzheimer's disease. If one of the parents has it, the gene, as for example, in Colombia, in South America, there are literally thousands of people carrying that gene. And so it's very predictable. If they have that gene, they will get dementia, and it will happen 10 to 30 years, or 20 to 30 years earlier than natural Alzheimer's disease would be for us. So they're hit in their 50s. Now, let's see where this is going. So these cases, so in the womb and early development, these affected people might have 20 repeats. Well, that's fine, that's consistent. I mean, they get by, and they get by for decades. But, and this is sometimes a slide, a picture is worth 1,000 words. Because here it is. You just watch it. This is a very elegant study here, but you have to follow me on this, because what they did, they had access to they had a surgical access to the basal ganglia here, and could take biopsies, of course, with the patient's permission. Why were they in there in the first place? Because to put a lesion in to control the abnormal movements. Okay, those choreiform movements I was talking about. So, and the different colors of red or pink on here really are the 6 patients that they had data on for the number of repeats. Well, follow this. Think of this as a lifetime here, and might have started out with 20 to 30 or 40 repeats, and for decades and decades and decades, not much is happening, and then the number of repeats starts to climb. When it reaches around 80 repeats, it really starts a steep rise. And by the time it hits 150 or more, that's toxic to nerve cells. The cells are probably going to die. And for any one subject of these 6 subjects who all had the Huntington's disease. Here, most of them, you know, if you looked at most of the cells, well, they had 50, 60, or 70, but some of the cells, some of them had up to 800 repeats. An extraordinary thing. So what's the lesson learned here? The lesson learned here is that this neurodegenerative disease is a biphasic disease. It has a long period of many decades when the person is clinically fine, functioning fine. Remember I told you you had to have about 50% of the cells affected, okay, before you got symptoms. And then that's a steep climb here. So what does that mean? If you were going to treat this, if you actually found a treatment that could stop the DNA here, or this particular gene, from creating so many repeats, these triplet repeats, you'd fix the disease. So that's the point. Now, transpose that kind of thinking to Alzheimer's disease, frontotemporal degeneration, Parkinson's disease, ALS. All of these neurodegenerative diseases are all protein disorders. They all are featured by a specific protein that's abnormal. Not the same protein, but an abnormal protein. And they probably, using this model, they probably do have, well, they do, clinically anyway, have a long period here where there's nothing going on clinically. But we know, for example, in Alzheimer's disease, that in this period here, if you do a functional MRI study, or if you do a bioassay for beta amyloid or tau, you can identify people at risk for developing Alzheimer's disease in this silent clinical period, which is the ideal time for a preemptive strike if you actually had a good way of treating it, right? So that really makes sense. I thought it was such a beautiful, we have no such clear example as this for Alzheimer's disease, but I'm sure this is the paradigm for others. So that's a great thing to realize. So now the quandary here is, if you have somebody, well, my daughter lives with a certain prospect because there are 4 of her people on her side of the family going back have had Alzheimer's disease, and fairly close relatives, including Jan. And so what are the prospects of her developing Alzheimer's disease? Well, they're high. But the time to treat it is actually now. She's 53 now, and so this is true of all of these neurodegenerative diseases. The same could be said for Parkinson's disease, ALS, for sure. Just different proteins affected, but they have this long kind of run-up period, asymptomatic, and yet stuff is actually happening behind the scenes at a biochemical level. So I thought that was an elegant way of driving that point home. So one of the things we're going to talk about in the newer session is the evolution of evolution, and that has some applications to disease, which we'll get into. But I just mentioned that Darwin and Wallace did a brilliant job in the mid-1800s, but they didn't know anything about a gene. And we didn't know actually about DNA until 1953, at least with Watson and Crick. And to be more explicit, how those genes actually work for the next 30 to 50 years. We're still finding out about that kind of stuff. But that kind of evolution is evolution on the slow track. But a lot of evolution is on the fast track. It happens much more quickly. And why does that happen? How does that happen? So we're going to talk about that. I think that's that's the biggest thing in biology kind of coming up now. I think. That's a really hot area. Now, why did I stick up this? Well, you know that the Earth goes around in the annual rotation around the sun, right? And the orbit is usually circular, or not usually, but it varies from circular to elliptical. And why is that? Because of the combined gravitational effect of all of the other planets circling the sun, the sum total of that gravitational effect changes the orbit of the Earth around the sun enough to produce glacial periods and interglacial periods about every 100,000 years. Wow, who would have thunk of that? And that has really big implications, doesn't it? Because when humans and pre-humans were doing their thing and making treks and spreading out into Eurasia and beyond, whether they could do it or not very much depended on the climate. And if the climate was conducive, meaning there was water and vegetation and animals and not too cold, then that was a good route. And North Africa and much of Saudi Arabia, northwest Saudi Arabia, was like that. And we know from satellites that there were lakes, large lakes, in what is sand dune now in Saudi Arabia. And so this cycle has been going on for as long as we've actually looked. And so in the great creation story, here are these cycles for 2 million years. That's just, it's actually going on over here, but the study only went out to 2 million plus. So here are a series of, we are here. Modern humans entered the picture here, 0.2. So our species, sapiens, that's when we came into the picture here. And our genus, meaning Homo, entered the scene down here. And then something extraordinary happened here, related to this pattern. And what was it that's happened? Now, some of you have seen this before, but it fits so well into this story that I'm going to show it to you again. This is one of the most impressive slides I've ever seen, because look at it. This is based on genetic studies, mostly. You can go back millions of years and to trace ancestry. And this is the estimated population, world population, of pre-modern humans. So around 100,000, 900,000 years ago. So this would have been late Erectus, or the Heidelberg species, a brain almost our size, creating art, crafted tools and weapons, did a beautiful job, and must have had some imagination and interest in beauty to have done that back here. But then look what happened. They crashed from 100,000 down to fewer than 2,000. And not only that, but remained that way for 100,000 years plus. I mean, we wouldn't be here if that thread hadn't held. Isn't that extraordinary? And it's not made up, because if you look for fossils during that period, it's very hard to find any fossils dating to that period. So there weren't living pre-humans back then, and that's the fossil of it. And it appears to be related. And furthermore, although it recovered in here, it was more or less a stasis here until the great out of Africa movements in here within Africa, movements within Africa and outside of Africa, and incidentally, this is when our species enters the picture. So it's not extraordinary. You put all of that together, that a near extinction event here happened because of the change in the glaciation period, because the orbit of the sun, or at least of the Earth around the sun, has changed enough on a 100,000 year cycle to make most of Africa arid. Isn't that extraordinary? Who would have thunk that up? I mean, you talk about a creation story. That's a survival story on a grand scale. It's really quite extraordinary, and that evidence holds up. Oh, sorry. Now we go back. Now they've gone. They keep going in this different groups, and this really shows the patterns of migration going back. Now, this is on a grand scale. We like to think of everything really happening 2,000 years ago, or if you're in Niagara Lake, it happened somewhere in the 1700s. And but this grand scale is so this is really 2 million years back. We're looking 2 million years back at migration patterns based on genomic studies of modern humans. Sounds preposterous, doesn't it? And if it's dark, if it's really dark, that's the oldest. If the pinkier it gets, that's the more recent. So that's really quite extraordinary, these migration patterns. And of course, here we are with borders, and arguing about borders, and keeping people out, or throwing them out. And there was a time actually where there weren't any borders. In fact, for 99.999% of our history, human history, there weren't any borders. So it really gives you another window onto things, doesn't it? And this is by species. So this is the habitat preference, different species. So just it's quite wonderful how they actually do this kind of stuff, and I don't have time to kind of shed light on it there. But there's Homo erectus. Homo erectus, by the way, first found in Georgia. I think 7 of them were found, and a skull not much larger than a chimp. But anyway, Homo erectus. But Homo erectus, Mary Leakey may have complained that he was dim-witted, but if so, erectus is the longest surviving hominin ever. I mean, the last one died out 100,000 years ago. So they were doing something right. And they got around on the east Africa here and into Eurasia and that kind of thing. I mentioned the Heidelbergs here, mainly because they were found in Heidelberg, in Germany. But anyway, the first example of it. But this is a late form, a larger brain form of erectus. The Neanderthals, well, they managed to impregnate Denisovans, cousins out here, but there weren't many in Asia. Almost all of them in Europe and in Saudi Arabia, northwestern Saudi Arabia. In fact, there are Neanderthal footprints in the lake bed during that interglacial period, right? And of course, Homo sapiens went all over the place. So it's nice to see where we fit into all of this, doesn't it? Mm. And there's the increasing. Well, Neanderthals had bigger brains than we did, but maybe not as clever. And just bringing it up to date. I mean, these are the dispersals in kind of recent history. What would we call recent history? 30 to 60,000 years ago. I mean, when I went to school, And for much of my university time, everything I heard, especially in high school, public school, was about the British Empire and European history, and not much Canadian history. And it was usually a picture book for Canadian history with a lot of Indigenous people, but not much else. But this is history on a giant scale, isn't it? And it's really quite amazing how they got around. Some of the detail I mean, it really did move. It spread out. I mean, as I mentioned in one of these talks, this is not a wagon train leaving kind of the east coast of the U.S. and heading to California in one long trip. These are groups moving maybe 50 miles, 100 miles, settling for a period of time, maybe a long period of time, maybe some of them died out in that time, and a lot of that kind of happening. But in the sum, they covered long distances. And I absolutely love this. Absolutely, one of my favorite pictures. I want to, if I could talk the Lake Report into doing it, printing my favorite kind of pictures, because this is one. And why is this one so important? Because these are prints that were made by adults and children. And there were, I think, 27 children, and the rest were adults. I think there, what was it, 67? No, 77. There were 77 of them. And it could have been us, because the adults are sauntering along at a slow pace. They're not making large footprints. They're close to one another. They had to have been talking. They had to be. You don't cluster that close without some form of communication. And it wouldn't have been sign language. And the kids are doing what kids do. They were jumping around on one another, and, you know, so I mean, it could be any summer beach anywhere. And I thought it was wonderful because in that same period, that 110,000 years ago, that's when Saudi Arabia was kind of open and had lakes, and their last time. So that, think about that, all that gravitational effect. So, and I'm not going to go any further. So I'm going to say goodbye to this one, but I did want to give you a taste of where I'd like to go with the next series, because I think there's we are storytellers as a species, and these are grand stories on a large scale, and sometimes very intimate scale, because sometimes you get a sense, like in Blumba's cave, of artists who kind of created little toolkits for themselves with ochre and maybe not brushes, but painting sticks, that kind of thing. So you had a sense of a stable life, long enough to be there for some time, and maybe that'll be what somebody discovers about us in 100,000 years. And any thoughts about things or not? Yeah, Ross? No?
Try to keep up.
Yeah, really? No, it's 3. Yeah.
So just, you were talking about leading into your next series.
Yes.
So, not sort of what's remaining in this series, right?
No, I've had, I talked to Debbie several months ago about, because there's certain things I've avoided getting into, and I think why, and I think one of them relates to the storytelling business, and even though we don't have voice tracks and kind of books going back very long, we have stories nonetheless for people. And so I think it's a really interesting story, and there's so much really good work going on now. I mean, this has just blossomed like this in the last 50 years. Yeah, it's partly because of the tools. Dating has become really accurate, and
How so?
yeah, and dating.
Yeah, how so?
Oh, different methods for doing the dating. That's worth a whole session right there. Because after all, how do you make a claim? Well, all these dating things are claims. How good is that evidence? Well, it's actually surprisingly good. But there are errors in it, and so I think that's worthwhile doing, and I think we're spiritual beings as a species. Neanderthals were too. I don't know how far back that goes. My guess is it precedes modern humans and Neanderthals. Probably goes back. Maybe 1 million, 2 million years, to the beginning. I mean, I don't think early cattle or bears were looking up and wondering what's going on in the heavens.
Right.
There was a time, obviously, when some species, our ancestors, some of them, looked up there and wondered about what's happening, especially there was no other light contamination around. I mean, it's like going up in Maine where there's no background light and you can actually see the lights and see the Milky Way. And yeah.
To get back to, sorry to interrupt, but to
Yeah.
get back to the subject of today
Yes.
and the last few weeks, I missed the first 3. And I
Oh.
wanted to ask you, because I didn't know about them, but I wanted to ask you about, have you discussed ataxia and things like that as part of peripheral neuropathy, or is it?
Oh yes, ataxia is, I mean, unsteadiness walking. Yeah, it's very much a feature of that. It has a central and peripheral component. There are certain receptors that we have in our skin or subcutaneous tissues that are very sensitive to your position. And then, of course, we have the inner ear, vestibular end organ, and there's a central apparatus for that too. It's a fascinating subject, actually.
Are you going to be covering it in the, I mean, I understood there were another 2 lectures in this particular subject? Or am I wrong?
Oh, was that? No, I don't think.
So this is the last one of this?
Of this.
Okay.
But that's actually one that would be one series that I would love to do is actually walk people through how we actually examine the brain and relate function to structure and imaging studies and that kind of thing, because there's a lot of really good data on that stuff now, and some of it is very tricky to sort out, and being off balance, you can be off balance for a whole lot of reasons that not only relate to the cerebellum and the brainstem, but the peripheral nervous system as well. And one of I did show a case here in the series that one of my old colleagues in Boston sent me a copy of, and it was a patient with B12 deficiency. Yeah, do you remember that? Okay. Well, that patient was actually quite unsteady walking. Well, B12 deficiency characteristically involves the back of the spinal cord, some of the sensory fibers that give information about position and movement, and on the side of the spinal cord, the same, because they call them spinocerebellar tracts. the information's going up to the cerebellum. So, yeah, no, I think that would be a very interesting one. In fact, one thing I used to do with the students one time is I'd kind of draw a great big brain and say, okay, let's go through the neurological examination. And every time we come to a part of the examination, I will draw on the brain and the spinal cord what systems I'm actually testing. Show where those systems are. It's a really interesting exercise because at the end of it, you realize how much you haven't examined. You certainly sampled widely, but you haven't covered anywhere near the whole ground, for sure. And
So why do we have all that in our brains? Because you said earlier, and I've read this, that if something is evolutionarily not used, why would anybody keep it? So
well,
what
in the
are all
nervous
those things doing?
It is true that if stuff isn't used, those parts tend to become vestigial. They never quite disappear, but they become vestigial. And others that what my daughter reminds me of, if you want to see a really plastic of evolution in action in a short time, teeth. Because if people change their dietary habit, it affects the jaw muscles, and the size and the position of the teeth. And a perfect example of that was off of Croatia. There were several islands, and on one island there were lizards, and the lizards ate only insects. That was their only diet. So what the investigators did is they corralled a bunch of them and moved them to a nearby island where there weren't any insects and none of them. Well, they went back about half a century later, or not quite that, and wow, the lizards had really changed. They had big jaw muscles, and teeth were big and strong, and they became vegetarians. And if you're vegetarian, I mean, you, after grubs, you needed big, powerful teeth to kind of break the stuff down, and bigger teeth, and that happened in something like several decades. So evolution can be very quick. Now, one way of thinking about that, is it something new that happened? What happens, for example, sometimes on the Galapagos Islands, depending on the season, or at least the year, or maybe 100-year cycles, or even shorter cycles like that, beak sizes and length can change almost within a season. How does that happen? Depending on the food. They actually carry copies of the genes, the requisite genes, to change. So given the environmental stimulus, they don't have to create an elaborate gene system to support it. It's already there. And we do this with cichlid fish in Lake Victoria in Africa, where one species evolved into several hundred, and very different looking in size, the size of the jaw, the color, you name it. And what happened when they looked at this, these later fish had kind of copies on the wall of genes that they could go to when the environment favored those adaptations. You follow what I'm saying? Yeah, so the tools were already on the shelf. It's like messenger RNA was on the shelf when COVID came along, thank goodness. Well, biologically speaking, in our genome, we probably have copies of other ways to go. And given the right environmental stimulus, we can change fairly quickly.
So there's a good chance we could get smarter real fast, which we need to do.
Yeah, well, that's what I want to deal with, intelligence. The evolution of intelligence, right up through AI. That's an interesting one, yeah. Okay, well, thank you. Well, it's kind of fun.